of the our conference, and I think that we all will be excited to hear the upcoming lectures from on the topic of the common movement disorder in Indo-China region, which will be given by Professor Norlina Mohammed Ibrahim from Malaysia. And she very well fit with this topic on several reasons, but importantly, she is a part of our task force of movement disorder in Asia, which is under the MDS Asian Oceanian section, and even more important that she will become the chair of this task force. So she very well fit for this topic, and welcome you all to this lecture. I understand that this is pre-recorded and it will be played right after this. Norlina, welcome. Good to see you, even though virtually.
Good to see you, Rongroj. Thank you for the kind introduction. Sorry I couldn't be there.
Not the problem. Okay. Would the lecture be ready? Live lecture? Norlina, this is my apology. Are you doing the live lecture? It's not pre-recorded, is it?
No, I actually I had pre-recorded, but if you would like me to do it live, I can also do it live. I thought pre-recorded will help with the videos. I'm just worried about the videos.
I think we'd love to see you live, actually. Yes.
Is
okay.
That so? So just give me one.
Okay.
One second. I will do it live then.
Thanks so much, Lina, because I was told initially that it was pre-recorded, but we'd be even happier to have your live lecture.
Okay. I will share my screen now. Okay, I hope the videos play well. If not, we will probably could switch to the pre-recorded. You can hear me well, right? Yeah, okay.
We do.
Okay. Let me give you a share screen. Right. A very good morning to everyone. I am Norlina Mohammed Ibrahim. I'm a neurologist from Malaysia, and it's an honor, and it's very nice to be virtually in this conference for the first time. And thank you, Professor Rongroj and Dr. Thai and the organizing committee for inviting me. My lecture is on common movement disorders in Indo-China, and there are a number of topics that have been already mentioned, so please bear with me. There might be some repetition. Just allow me to start my lecture. So let's go back into the history of Indo-China. Indo-China was coined in the 19th century, signifying the Chinese and Indian influence in this region. And we are part of Indo-China, and we consist of 6 countries: Cambodia, Laos, Malaysia, Myanmar, Thailand, and Vietnam. And we're also known as mainland Southeast Asia. And our population is approximately 243 million. And our ethnic group consists of Austroasiatics and Austronesian. And we have a similar cultural practices, although our ethnic group is relatively diverse. So it's interesting to study the cultural and influences of India and China in this region. So some of the movement disorders will be influenced by this, our ethnic group in this region. So this is just a nice, colorful slide which shows the colorful cultural practices and heritage. And I hope I've captured all the thank you in all the languages accurately. I may not know how to pronounce them, but that's it. It's a very beautiful region. So just when I was researching on what's common in this region, we need to see what's common globally. So movement disorders, and as you know, as you have seen, can be a manifestation of many neurological conditions. And this is a figure taken from the global burden of study, Global Burden of Neurological Diseases published in the Lancet Neurology, and you can see that stroke remains the commonest neurological disorder which leads to death and disability-adjusted life years. And if you see Parkinson's disease, it's very small there, but it still contributes to burden of disease and death. But having said that, movement disorders could be a manifestation of any of these diseases. So when I wanted to look at what are the common movement disorders in this region, I came across this very nice paper by our colleagues in Myanmar. It's a paper published from patients admitted in Yangon General Hospital. And basically what they looked at was they looked at the frequency of various neurological disorders combining inpatient and outpatient, and again, cerebrovascular disease and CNS infections tops the list. And for the movement disorder, you can see Parkinsonism, hyperkinetic movement disorders, and cerebellar ataxias and hereditary spastic paraplegias contribute to referrals. But if you see collectively, their percentage is rather small. So when I was given this talk, I was thinking about what shall I talk about. So I have divided the movement disorders into genetic and non-genetic. And because the prevalence of genetic movement disorders in this region is not really well known, I've decided to focus on non-genetic movement disorders. And we can divide these into three broad categories. First, looking at diseases that are more prevalent among Asians, whether they're metabolic, vascular, or infection. And we could also look at unique or culture-related disorders. And common disorders globally would still be common in this region because by virtue of it being just the commonest disorder like Parkinson's disease and so on. So let's start with the first group. So for this, I have a number of case illustrations, and I know there are some of the disorders have been mentioned previously, so please bear with me. So let's go with the first case. I think all of you are experts now. I hope my video plays well. So this is a 45-year-old patient with diabetes and hypertension who presented with right-sided involuntary movement. And this is very classical. You saw this and you probably know the diagnosis already. So it is certainly irregular, random movements, which is somewhat dance-like, involving his distal lower limb and also partially his upper limb. So this is hemichorea. So let's go on. So this is his CT brain finding, and his random blood sugar was 25 millimoles per liter. And so this patient certainly has Hemichorea-Hemiballism and hyperglycemia, also known as diabetic striatopathy. And diabetes is actually a very common disorder in Malaysia and I'm sure in parts of Indo-China. And because diabetes is very prevalent in our region, we need to recognize this syndrome. And it was first described in 1960 and has been reported to be more common in Asians. Up to 70% of cases reported occurred in Asians, and it's caused by hyperglycemia, but it can also happen with the administration of high-dose steroids. So it's not always hyperglycemia that causes this. It can also happen in patients who are given methylprednisolone and so on. Estimated prevalence is about 1 in 100,000, and the patient usually presents with acute or subacute hemichorea or hemiballism in an arm-leg distribution, but rarely it can be bilateral chorea or monochorea, alternating hemichorea or generalized chorea. The chorea typically responds to the treatment of hyperglycemia, but in some cases it may require other medications to suppress the movements, especially if it's quite persistent. So the the medications that we use here is typically dopamine antagonists, but we have moved away from that and started to use tetrabenazine. It's not widely available in Malaysia, but we have to bring it as an import permit license. So now we are able to use tetrabenazine, and clonazepam sometimes might work. So the pathophysiology is due to decreased cerebral blood flow to the basal ganglia, causing reduction in the striatal GABA activity and increased in the pallidal activity. So if we just look at the MRI changes. You can see the MRI shows hyper intensity on T1 with corresponding hypo intensity on T2. And I think we all are well aware of this syndrome already. So let's move on to the second case. This is a case of a 60-year-old man with diabetes as well, also has end-stage renal failure on regular dialysis, who presented with involuntary movement for 3 months. He has no family history. Kanan boleh ke depan dua. Sentuh hidung. Sentuh jari. Sentuh jauh. Sorry about the video. It's trying to register. Boleh tak saya minta Encik Hamzah tahan, jangan gerak langsung. Actually, what I'm asking him to do is to try and suppress. So he actually could suppress it reasonably well, but what he had was a generalized chorea, which was quite subacute. It had occurred for 3 months, and we had done all investigations, including manganese level and so on, and looked for acanthocytes. It was not present. And what we found was, we saw this on his brain imaging. So we could see these bilateral symmetrical basal ganglia lesions. And you can see in the diffusion weighted imaging, there's restricted and no restricted diffusion. So we were a bit puzzled. We knew obviously this is a metabolic condition because it seems to be swollen, but we cannot figure out why exactly this patient had this. So when we looked up the literature, so when we see any bilateral symmetrical basal ganglia lesions, of course, we have to go through some differentials. For example, carbon monoxide poisoning, mitochondrial lesions, Wilson's disease, whether the patient has had extrapontine myelinolysis or hypoxic ischemic encephalopathy. So this patient had neither any of those conditions. So what he has is syndrome of symmetrical and bilateral basal ganglia lesions in diabetic end-stage renal failure. And we recently did a systematic review on this, and it is an uncommon condition and first described in 1998. It can present with acute movement disorder, which presents exclusively in patients who are on dialysis or with end-stage renal failure. And usually patients, in 99% of patients, they also have diabetes. Patients may present with Parkinsonism or chorea and tremor and gait difficulties. So while we are collecting our cases, we came across 3 patients in our center, and then we had 2 more from other centers. So we compiled these cases and conducted a systematic review. So why this happens, it's thought to be related to acute severe uremia and the shift in the uremia, in the urea levels, with a combination of diabetic microangiopathy and subclinical hypoglycemia. So most cases resolve following regular or more frequent hemodialysis, but relapses have occurred, and even the MRI lesions can regress and recur again. So the diffusion weighted image and the susceptibility weighted imaging indicate that this could be a vasogenic edema related to metabolic changes or metabolic shifts. As you know, the basal ganglia structures are very vulnerable to toxic changes because of their high energy requirement. So it could be, this could explain why the patient developed these lesions in the basal ganglia. So this is just to illustrate the recurrence of lesions. You can see in the topmost scan, there was this lesion, and then in the second one, it has regressed, and then it recurred again, and then it regressed again. So what we did for this patient was to make his dialysis more efficient. We spoke to his nephrologist and we asked his nephrologist to optimize his dialysis, which somewhat improved the condition. And we had a few other cases. Another patient had presented with Parkinsonism, but the patient was lost to follow-up. So basically what we need to do is to improve the dialysis efficiency. Maybe you need to improve the frequency or change the membrane and so on, but we need to discuss with the nephrologist about that. So this is our review, which was published recently in the Journal of Movement Disorders. And I said we have found 72 cases reported and more than 50% occurred among Asians. And the treatment is to have a more regular and efficient dialysis. And in 1/3, there was a complete clinical resolution. And in 1/3, another 1/3, there's radiological resolution. So this is next case, moving on. This is a young man in his 20s with sudden onset of involuntary movements, which were intermittent. So again, I think you would know the answer because a young man with involuntary movement, oops, sorry, you found the answer, but anyway, never mind. So this is a so you can see again our theme today is Korea.
Okay, now 100 minus 7 again.
The voice of Dr. Chi, I think he's here. So basically, we're asking him to do mental tasking to see whether the movements will alter. So asking him to count backwards from 100. And you can see the movement is persistent in his right leg. When we're assessing involuntary movement, we should look at it at rest and look at what type of movement it is. He is completely aware it's not a seizure. I mean, you could have focal seizures, but this doesn't resemble any motor seizures. And there's no weakness. He just has this distal movement involving his right side. And obviously being young, we screened him for everything. And when we did the MRI, there was some scattered white matter lesions. And we proceeded to doing MRA and time of flight and found multifocal stenosis of the bilateral MCAs, which was more significant on the left side, and short segment occlusion of the left M1 segment with the Moya-Moya-like pattern of collateralization. His distal ICAs were normal. So what this patient had is Moya-Moya disease associated with hemichorea. It is rare, but it is something that we should not miss, especially when patients present with hemichorea and they're usually young. And to date, there are about 17 case reports, and it's thought to be due to reversible striatal hypoperfusion on SPECT, although there are more recent PET studies showed that this Moya-Moya syndrome leads to abnormal functional connectivity in the basal ganglia thalamocortical circuits. But we're not sure whether this is due to hypoperfusion or hyperperfusion. So it still can be debatable what really causes this hemichorea in this patient. As you know, Moya-Moya disease is a chronic progressive occlusive disease of the circle of Willis and surrounding vessels, causing the formation of weak collaterals with increased risk of stroke. And we know that East Asians have a higher prevalence of Moya-Moya disease, particularly Japanese. And given the Chinese ancestries in Indo-China, I believe that we would have a higher prevalence of Moya-Moya disease in this region. And there was a study which compared compared ischemic stroke and Moya-Moya disease, and they found that being Asian confers a higher odds ratio of having stroke due to Moya-Moya disease. So this is something that we need to bear in mind. And there is a genetic predisposition for this, which is in the RNF123 gene. And this particular variant, the variant R4810K, is observed only in the Japanese and East Asians, but not in the Southeast Asian cohort. So we need to look for our own variant with Moya-Moya disease. So let's move on to the next group. So there's infections, of course, we being in this region, we are prone, we have a high prevalence of infections, particularly Japanese encephalitis, dengue virus, Nipah virus, Zika virus, and of course the other endemic infections. We also very common tuberculosis infection, parasitic infection, neurocysticercosis, bacterial infections. They can all lead to movement disorder. They can be acute and reversible, related to inflammatory changes, but when there's striatonigral necrosis, such as in Japanese encephalitis, you can have persistent neurological deficits. And also if there are any lesions, it can also lead to neurological deficits. So Japanese encephalitis is an inflammatory disease of the brain caused by Japanese encephalitis virus. It's common in certain parts of Asia. I think Vietnam, Cambodia, and Thailand sees more than Malaysia. Malaysia, the cases have reduced tremendously due to vaccination, but we do see isolated outbreaks, especially in East Malaysia, Sabah and Sarawak. And the movement disorders can be divided into acute phase or more persistent phase due to bilateral nigral necrosis. So I'd like to share a video from this publication by Agarwal in MDCP 2021, which gave a video anthology of all the infection-related movement disorders. It's very, very interesting, and this is something that I think we need to be aware as well. So let's look at, look at the video.
Persistent movement disorders due to Japanese encephalitis. Segment 1. 4-year girl developed acute Japanese encephalitis, bilateral nigral necrosis, and levodopa-responsive Parkinsonism with motor fluctuations and dyskinesia. Therefore, levodopa was replaced by dopamine agonists. 4 years later, during dopa-off phase, she has Parkinsonism and generalized dystonia. She looks unhappy. There is dramatic on with rock and roll. The response is sustained. Segment 2. 4-year boy developed acute Japanese encephalitis, bilateral nigral necrosis, and levodopa-responsive Parkinsonism with motor fluctuations and dyskinesia. 4 years later, in the dopa-off phase, he is unable to hold his neck, stand, or walk due to hypotonia, Parkinsonism, and left hemidystonia. There is dramatic on with rock and roll. Segment 3. 4-year boy developed acute Japanese encephalitis, bilateral nigral necrosis, and severe generalized dystonia. 18 years later, he has persistent generalized dystonia. Right side is more affected. With levodopa, there is dramatic improvement.
So I'll stop there. So we can see that this Japanese encephalitis can lead to persistent neurological sequelae, but they're quite responsive to medications in these 3 cases. Levodopa in this last case and dopamine agonist. So this is something that we should consider when we're treating patients. So let's move on to the next case. This is a very easy case, but let me see. Oops. Unfortunately, I cannot play this video, but okay, it's probably in the recorded one, but not here. So this is a middle-aged man with unilateral involuntary facial movement. What I wanted to show was this, he had this clonic contraction of his right face and also his right-sided eye, orbicularis oculi, and face, and what he has is hemifacial spasm. Hemifacial spasm is not really a true movement disorder, but it is thought to be a segmental myoclonus. It's not a true spasm, but it's thought to be due to compression of the cranial nerve 7 by arterial lobes within the posterior circulation at the pontine exit, leading to aphatic transmission. Why I brought this here is because it is also a movement that is common, thought to be more common among Asians. So there are no epidemiological studies, but there are support from published studies from within Asia, and a study which had looked at the patients who presented with hemifacial spasm in the Baylor College of Medicine. So they found that Asians were more likely to suffer from hemifacial spasm compared to non-Asians. that was from their center. So they postulated that hemifacial spasm is more prevalent in Asians. And why is that so? Perhaps it's due to the smaller posterior fossa cranial volumes in Asians, and certainly the study by Chan in neurology from Singapore showed that females have indeed smaller posterior fossa volumes, and we know that hemifacial spasm is slightly more common in women. Also, perhaps there is a genetic predisposition or anatomical reason for hemifacial spasm to be more common in Asians. So this is just to share with you this interesting Babinski sign. So whenever you see a patient with hemifacial spasm, there is an elevation of the eyelid when the patient tries to close his eyes. So this is a Babinski 2 sign described by the person, the Dr. Babinski. So it has a very high sensitivity and specificity to distinguish between hemifacial spasm from blepharospasm. So they will, as they try to close their eyes, the ipsilateral eyelid will elevate. Okay, let's move on to the next, the second syndrome. So this is a unique and culture-related syndrome, and then we'll go to the next syndrome after that. So cultural syndrome, this is very interesting, and this is a video shared with me by Dr. Lim Tien Tien, who's here. So it's a very interesting video. It's a Malay man. He says he cannot control the movement, and he's very, very happy about it. And he drops his paper. He does hypoprexia. Again, he drops his paper, and he's very happy. You can see that the amusement. So there's forced obedience, there's vocalization. So he's been asked to look, and he just looks. And then there's coprolalia as well. Okay. This is the next patient. This, I believe this is an Indonesian lady. Whenever she gets startled, she just speaks. So forced obedience. She's been examined by Dr. Lim. Staying there. So there's a lot of vocalization, startle reflex, and they're very startled and they get very jumpy, and this is what we know as Latah syndrome, and it's called Yaun in Myanmar and Bah-tsche in Thailand. It's a culturally stereotyped neuropsychiatric startle behavior, and usually it responds to variable and sudden and unexpected external stimuli, as you can see, resulting in echolalia, coprolalia, palilalia, involuntary vocalization. Sometimes what they say does not make sense, echopraxia, and forced obedience. It was previously known as the malady of the Malays, and typically occurred amongst the Malay women of Malaysia, of the Peninsula Malaya at that time, and Indonesia. And there's exaggerated nose-tap head retraction reflex in some patients, which is a hallmark of hereditary hyperexia. So there's no specific treatment for Latah. Usually we involve the neurologist, psychiatrist, psychologist, caregiver needs to be informed, and nurses. What is Latah really a neurological disorder? You know, sorry, this is just to show you the head retraction reflex of the Startle syndrome before I go on. So just share with you this video on how to perform this. So you can see you can tap on the nose and the patient will retract his head. And this is a hallmark feature of Startle syndrome. And it doesn't, they don't habituate. They keep retracting their head. And this is another patient. So if you do this to a patient with Latah syndrome, they would have exaggerated reflex. Okay, that's fine. Okay. So what is Latah syndrome? So it is again, it's thought to be a neuropsychiatric disorder, and the patient, as you can see, are very, very amused by it, unlike tics, where patients would be a little bit upset by the tics. So Latah syndrome, are they a form of tics? We don't think so. Or Tourette syndrome, because of the vocalization. It's quite different, because Latah syndrome is stimulus-induced and not preceded by premonitory symptoms. And echopraxia and echolalia are not feature of tics. And the suggestibility of movements, which favors a psychogenic cause. And yeah, actually there's a very nice review by Dr. Lim Tian Tian, I think was shared previously, that shows the component of Latah syndrome. I think Professor Rongroach is also the author of this very nice review on Latah. So to be honest, I don't see too much Latah now in my practice, but I think we still see it here and there. So it's important to recognize that in this region. So let's move on to the last syndrome, last disorders actually, because I thought we should still talk about common disorders worldwide that would still be common in this region. So I would like to highlight a few reversible movement disorders that we need to be aware of, and some of them have been mentioned. So just to go through quickly, this is a 33-year-old lady who is pregnant, presented with balance difficulty and hyperemesis gravidarum. And if you look at her eye movements, so she has horizontal nystagmus and vertical nystagmus. So when we do the finger nose testing, she definitely has a cerebellar syndrome, and she's not able to walk. And so what do you think this patient has? Yeah, I think it was mentioned previously. So don't think I can hear anyone. So I will give the answer. Yeah, the patient has Wernicke's encephalopathy due to vitamin B1 deficiency. And we know that this is a triad of encephalopathy, ataxia, and ophthalmoplegia, and usually occurring in chronic alcoholics. Patients who are malnourished, but we do see that currently in patients with hyperemesis and post-bariatric surgery, now that it has become a treatment for obesity. And in crowded camps, actually we have seen a few cases of Wernicke's encephalopathy in patients who, unfortunately, refugees who traveled across the land to enter Malaysia, and they were staying in crowded camps. So this is something that we need to recognize. And you only need 2 to 3 weeks of no intake of vitamin B1 to develop this Wernicke's encephalopathy. And the MRI changes are characteristic: hyperintensities in the periaqueductal gray matter and the dorsal midbrain regions. And it's reversible and treatable with vitamin B1 injection, with thiamine injection. So let's look at this, another case. This was an interesting case I saw of an 80-year-old man who was still able to cook. He loves to cook. He was cooking for himself, but for the last 1 year, he was not able to do that. And he came to me, and this movement was not noticed by his family members. They just thought he had some difficulty with balance. When I saw him, there was this subtle finger movement at rest. His eyes are open. It's not closed. 98, 97. So he's doing the counting backwards to see whether the movements are accentuated. Again, his eyes are open. So he has chorioacetoid movement. So let's see how he does this. Asking him to touch his. So he doesn't have much ataxia, but he does have this chorea, distal chorea, and some adductoid movement. But interestingly, his movements are present when his eyes are open, unlike the pseudoathetosis that you would see in vitamin B12 deficiency. So he had absent reflexes, and he was found to be anemic with macrocytosis, and his vitamin B12 levels were low, and he was positive for antiparietal cell antibodies, and he had pernicious anemia, which was late onset. So we treated him with vitamin B12, and this is his movement. Now it's much better. He can resume his normal activities, and the distal chorea adductoid movements have resolved, almost resolved. Okay, so these are the two reversible movement disorders that I thought I'd like to highlight that we still may see because of it being common. And okay, just before I end, I would like to just talk about common disorders around the world and the phenomenology of it. And we can divide, as you know, movement disorders into hyperkinetic movement disorder or hypokinetic movement disorder. And what's common in these categories would be tremors, dystonia, tics in young adults, and Tardive syndromes. And I think we have seen quite a lot of examples of Parkinson's disease and secondary Parkinsonism yesterday. So I would just go through very briefly about tremor, dystonia, and tics, so that we're just aware of the phenomenology again. So this is a middle-aged man who came to me with worsening of tremor. Sorry. And he says he has difficulty walking because of the tremor. And there is a strong family history of tremor in his family. In a dominant history. So you can see he has tremor. Let me have a look at the video.
Kaki tak ada gerak Kaki tak ada gerak.
I'm asking about whether there's any tremor in his feet. Okay, so this patient has tremor on posture and action. It's not very prominent, as you can see, but there are some components of the tremor which appeared jerky. So I was worried whether there could be a myoclonus component on top of it. On top of that, he had fasciculations as well in his tongue, and it was a very puzzling case. And he was also positive for Kennedy syndrome, and when we did his genetic testing, he was positive for autosomal dominant tremor type 5. So he has two genetic conditions which confused us for some times, because he said his tremor is much worse than his family members because they just have mild tremor. So we explored this condition. So he had two conditions put together that caused a worse neurological disease compared to his family member. So this is another young man who presented with adult onset dystonia, and this is something that we will see very frequently. Usually dystonia in the adulthood is idiopathic, no trigger, but in this man it's related to frequent weightlifting. He goes to the gym a lot, and he said it started one day after he did his weightlifting, and a lot of pain. And it's just a very short video, and you can see the left torticollis to the left, some rotational component. And so this is something that we would encounter quite frequently as well in our region, regardless of where we are. So this is secondary dystonia. And lastly, before I end, this is, if it's a young patient, this would be the commonest movement disorder that we see. A young boy with irregular, involuntary movements, which are random. They're not myoclonus because they're just, they're a bit too, myoclonus has to be shorter. So this is a bit more complex and multiple. And we need to, of course, when we see this, we need to check for suppressibility, and we don't have that video. I didn't capture that on video, and this is partially suppressible. And there is premonitory urge consistent with tics. And similarly with this young man, also complex motor tics. And this would be common movement disorders in this region because of the age group and so on. So I think I'm not sure if I've reached my time, but basically I'd like to summarize here that Indo-China has rich history and culture with both Indian and Chinese influences. And certainly that movement disorders that are commonly seen may reflect the prevalence of underlying diseases. So for example, diabetes, metabolic diseases, infection, and stroke would still be common in our region. And of course, being the lower income, we fall within the low to middle income countries, and we would still see metabolic causes related to malnutrition and so on. So we need to recognize that and not forgetting the unique cultural syndrome. With that, I thank you for your attention. Terima kasih. Come on.
Thanks so much. Thanks so much, Professor Ibrahim. You very well highlighted different disorder, with a good case collection. Really, it's impressive. Any questions from the audience or even online for Professor Ibrahim?
Thank you, Professor Mohammed Ibrahim. Your talk is fascinating for me, very comprehensive, and I would like to have from your opinion about the cause of Latah syndrome in Malaysia. Maybe genetic, the Latah syndrome. And the second one, my second question is about the reversibility of dystonia and Parkinsonism in many cases of young patients with affected by Japanese B encephalitis. There's open the imaging. There is a necrosis of the substantia nigra, but there is a complete reversibility. How can we explain this phenomenon? Thank you.
Okay, these are two very good questions. So the first question on Latah syndrome, there was a hint that it could be genetic, but I don't think we were able to discover any genetic mutation in patients with Latah syndrome. But what we know now, it seems to be a very cultural syndrome. I think Professor Rongroch may have something to add. It used to be almost a performance-like syndrome amongst the Malays. So they used to have this syndrome and people would just, respond and laugh about it. It used to be something like they could be termed as the joker of the community. So I think there is a suggestibility to Latah syndrome suggesting that it is a psychiatric or a behavioral syndrome that can be that you can learn. However, the startle reflex is a little bit puzzling. That one is suggestive of hyperepixic syndrome, and we need to find out whether they have any mutation in glycine receptor like the hereditary hyperexia. Professor Rongroch or Dr. Lim, would you like to add on that?
Yeah, you're quite right. But since we have the first author with a recent review here, I think I would give that to Dr. Lim to address this.
Yeah. I think very nicely said by Prof. Nordina about Latah. how I started writing this paper was when I looked into, there were a few cases actually presented during the MDS, if you remember, many years back. And when I looked at Latah, it's quite common among Malaysians and Indonesians. And the patient that you saw, the first man there, was actually my staff. It was my attendant when I was working in Penang General Hospital. And it was so common. I had 3 more staffs in the administrative office who also had Latah. So I found it very, when I work halfway, then I'll suddenly hear a burst of laughter in the office, and I thought, what happened? And I go there and there's, oh, okay. They were actually amused by the Latah from the patient. But when I asked the patient itself, how do you feel about having this burst of symptoms of coprolalia, palilalia, forced obedience, and so on? Although he himself is not really that frightened, but it's stressful when you keep precipitating it. When you keep making him startle, then he gets upset and he gets stressed up, although he laughed over it. So I find that perhaps that Latah, all the description has been described mainly by the neuros or the psychiatric part, but the startle part perhaps is actually a movement disorder, and it's somewhat more to our Southeast Asian region. But there are other regions in certain parts of the world that are described but in a different name, and I think even in Thailand you do have something like that in a different name, and in Japan as well. So if you look at the literature, we do not really have an answer of what is the cause, but I guess it may be either genetic or multifactorial. There are certain comments on some aggravating factors before the onset of the Latah, things like some sexual problems that they had and so on. But these are all just description. And the descriptions were mainly in the psychiatric literature, and it was described by mainly the Caucasians who describe our problems. So I thought that this paper could actually make its way so that we actually concentrate on our own diseases, and perhaps in the near future we could actually go into the genetics and also the treatment of Latah, because some of the people do have problems with the condition itself.
Thank you. So maybe you're suggesting that Latah could probably even more common in Penang.
We may need to do another
you
study.
have already 3 staff with this type of the movement.
Yeah. But there is no family history though, although it tends to cluster in families. We find that, but there is no definite inheritance pattern to suggest that this is a familial, but at least genetic predisposition may be there. So we need to do more studies.
Yeah, probably it's likely to be heterogeneous because the videos of the cases that you show, particularly the second one, the phenotype is quite striking with the predominant startle that you mentioned. Certainly, not sure whether there could be different subgroup that have some genetics influence, or that they're not quite sure.
Yeah, because the 2 videos were different. I agree. Yeah. For the second question on striatonigral necrosis and how there was a great reversibility with ropinirole with after many years, I'm also quite puzzled because, to be honest, I don't see too many Japanese encephalitis myself. But we never thought of, we usually give levodopa and dopaminergic medications for patients who have infection-related movement disorders, and usually they respond well despite having lesions in the brain within the basal ganglia. So I'm not sure whether there's a presynaptic terminals dopaminergic are still preserved in these patients. We know that there are some residual terminals which are still present and which it enables the ropinirole to act on it. But we need to have a DET scan, I think, to look at how much, how devastated is the basal ganglia, but we don't have all that. But it's good to know that they respond. I don't know how many percentage though will respond entirely. I think there is a group that will respond, there is a group that will not respond, but it depends on the how severe the necrosis is. That's my understanding or my theory. If anyone else would like to add.
Yeah, I think that's a good point that you mentioned. I think that when we look in the literature, the disorder with nigel lesions can be levodopa responsive, and I think that you documented quite nicely with videos that you have demonstrated. But what I'm a bit perplexed here is the development of the motor complications in those with Japanese encephalitis you mentioned. And that is suggesting whether is there any ongoing degeneration after the static lesions following the infection, in which, I don't know if there any literature looking into that. Is there any evidence at all? But probably it needs some form of the longitudinal studies on those type of patients, if how they actually progress with some of the imaging or even pharmacokinetic studies would be very helpful.
Yeah, agreed. Yeah.
Any more questions from the audience? Okay, but before we end this session, Professor Ibrahim, maybe if I could ask you to share with us about what you are doing with the movement disorder task force on movement disorder in Asia. This is one thing that maybe I would like to ask you to share, because since we are in the Indo-China, we certainly would be a good opportunity to participate in this task force in any ways, the first thing. And then and the second thing is, as far as I understand, that you have some interest in genetic disorder in which it's not much study within the Indo-China. So maybe you have something to share with us, any initiative that you would like to do, and maybe is an opportunity for us to involve.
Thank you very much, Professor Rongroch, for this giving me this time and space. Actually, I have been working with Professor Rongroch and Dr. Priya in the Movement Disorders Society Asia Oceanic Task Force for the last 2 years. And we have done quite a significant progress in identifying genetic and non-genetic movement disorders that are common in Asia. And this task force consists of members from the Asia Oceanic region, and we have 3 publications that two have been submitted. One is going to be submitted very soon on genetic and non-genetic movement disorders in Asia. But for the second phase, what we plan to do is to look at, in the next 2 years, we're going to look at the burden of neurological diseases within Asia Oceanic region. And particularly, we need representative from Indo-China. We want to know burden of Parkinson's disease, particularly. We want to know how much how much Parkinson's disease is affecting our patients, and how much resources we have, and what are the capabilities of each centers within this region. And we know that within Asia Oceanic, we have different socioeconomic group as well. We have some countries which fall within the low to middle income country category, and we have some which are very in the East Asia, for example, they are in the high income category. And certainly there will be discrepancy, and we need to highlight this and help each other. And also, as part of my initiative in collaboration, please allow me to share one slide that perhaps which will help. I would like to invite our friends from Indo-China. This is a collaboration initiative initiated by Dr. Kin Mok from UCL. This is as part of the Global Parkinson Genetic Project, where he has set up an East Asia Parkinson's Disease Genetics Consortium. So you could ask why we are not East Asia, but what East Asia Parkinson's Disease Genetics Consortium is going to do is they're going to look at underrepresented population within Asia. And so far, I think Professor Rongroj, she has approached you, and I know he has approached somebody, a neurologist from Vietnam as well. So we would like to be inclusive and include Laos, Cambodia, and Myanmar as well into this group. And hopefully we can arrange a meeting in Kuala Lumpur to initiate a collaboration, a working collaboration between our centers so that we can enhance the understanding of genetics contribution of genetic contribution in Parkinson's disease within our region. We can have our own publications. We can have an Indo-China group, subgroup publication. We can work on this in the future, but we need to have a meeting. This is just an initiative that I'd like to share. And I'm also very interested in spinocerebellar ataxia. We have now worked with Indonesian colleagues, but we would like to engage our colleagues in Indo-China as well on spinocerebellar ataxia in Asia. And that's all, Professor Rongroj, that I have. Maybe I'll just stop sharing. We can open for discussion.
Thanks very much, Professor Ibrahim. Not only we have the Vietnamese colleague in this audience, but we have colleagues from Cambodia and Laos sitting with us too. And I have seen that they already took photographs of your slides, so I think you will be contacted soon.
Thank you. Thank you. Thank you for this.
All right. Without further questions, I would like to end this session. And thanks very much, Professor Ibrahim.